I think AML is like the poster child of, there is no really one patient that is the same as the other. We divide AML into some of these sort of subgroups based on ELN risk, where depending on the cytogenetics and molecular features, there's favorable, there's intermediate, there's poor risk. But if you really look at the sort of mutational complexity and the co-mutation status, even in subgroups which are common, like NPM1 mutated AML, we find the other mutations are just the combinations of mutations are so diverse that in order to actually search for one particular patient with a set of mutations and sort of saying, okay, how do other patients do with the same? It's like finding needle in a haystack. You actually can't find many patients with the same profile, which is why a lot of for the Harmony studies, the point is to sort of coalesce all the molecular mutation on patients, because it's important to have a huge data set to understand how patients are different. Even within our own known subgroups, we know that some patients actually don't behave in a good way as expected, and they tend to relapse when they were not supposed to. So increasingly drug development is, there's a group of drug that is sort of going for a whole population, and then there are these molecular targets, NPM1, IDH, TP53, FLT3, which are like sort of attacking the heterogeneity of AML. But that is, I think, one of the biggest challenges on understanding how patients would do it, because these questions are important not only in drug development but also decisions regarding transplant. How does one group of mutation differ from the others? Because you have one common set of mutation, but if you have the second or the third or the fourth, it completely changes how patients behave.